situations in Phaco. I also invite Dr. Amrita Sahani with us and Dr. Urvija Chaudhary. So to start the session, I would like to invite Dr. Urvija Chaudhary, and she will be speaking on Phaco machine, Phaco needles and choppers.
Good morning, everyone. Thank you, ma'am, for the opportunity. Thank you, Dr. Harbansh. So today I'll be talking a bit on Phaco machines, needles, and the choppers. The main role for a Phaco machine is obviously to emulsify the cataract and aspirate it out of the eye. And these are various machines. We don't need to get confused. They basically work on two main principles, which is a peristaltic and a venturi, both of which basically have to create a fluid flow and a balance between the vacuum levels. Both the peristaltic and venturi does this in a different way. So when we talk about the peristaltic pump, so this is a small demonstration. Here you can see the tubing above is adjusted with the handpiece where the flow is aspirated, and through this peristaltic pump, peristaltic movement of the pump, like contraction, relaxation, the water or the fluid or the BSS is aspirated out in fluid pockets. This is a flow-based pump, therefore the name, it's a flow-based technology. The flow is continuous and vacuum is low in the initial phase. Vacuum is created only when the tube is occluded with the nuclear piece. So this balance between the vacuum and flow creates the aspiration, the vacuum and the nucleus piece is cut and aspirated out. The drainage system is in the fluid bag, which can be rigid or the soft bag, and flow is constant until the occlusion, and then it drops down when the occlusion is created. In venturi pump, it is a venturi system where venturi system is based on pressure changes in the velocity of the gas. Here the compressed gas or the compressed air is thrown or pushed through a pipe of a larger diameter, and when it travels to a lower passage, the pressure is reduced, creating a vacuum. So this is the venturi principle. The compressed gas goes inside and it creates a vacuum in the low pressure zone, and this vacuum is created instantly, immediately. It doesn't create after the occlusion of the tip. It creates just when you press the foot paddle. So the vacuum is created instantly and when the tip even is when it's not included. So there is a faster rise time. You don't have to wait for the vacuum to get created. It is just there, and therefore the system is very quick. Flow will vary according to the vacuum levels. We cannot titrate the flow levels here. You cannot customize, and therefore because of the constant vacuum, the drainage bag is always a rigid bag. Rigid cassette is used here. This is the simple differentiation between the peristalsis. When the tip is not occluded, vacuum is low and flow is high. When the tip gets occluded, vacuum rises and flow reduces because there is a hydrostatic condition in the chamber. There is no inflow, so the outflow also stops. Whereas in the venturi, the vacuum is high. Even when the flow level is there, you have an instant vacuum, even when the tip is not occluded. And as soon the tip is occluded, the flow will reduce according to the customization done by the machine. So because of this principle, peristalsis gives a precise control on the flow rates, and therefore there is a lesser degree of, and it prevents the surge. Anterior chamber stability is well maintained, and it helps in better stabilization of the IOP. It is less susceptible to the fluctuations in the vacuum, and tubing occlusions can sometimes happen because of the kinking. Whereas in the venturi system, the cutting efficiency is very high because it can deliver a higher flow rate and it allows a faster emulsification. The anterior chamber stability will also be good at the lower flow rates, whereas if you increase the high flow rates as required in the dense cataracts, the chamber stability can little vary. So the things and the control should be very quick here. So it's advisable to, not for the beginners, but for the trained surgeons, it would better. And because of this increased cutting efficiency, the energy requirement is also low in the venturi system. Now the second is the handpiece that we'll talk about. There are two kinds of handpiece in the Phaco machine. One is the irrigation aspiration and one is the Phaco handpiece. Phaco handpiece basically uses a piezoelectric crystal here. There can be 4 to 6 piezoelectric crystals which will change the electric energy into a mechanical energy, the ultrasonic frequency, which will oscillate your Phaco probe, the Phaco tip, and will create the cutting motion, and it will emulsify the cataract and will do the aspiration. The handpiece will consist of a handpiece probe, the sleeve, and the sleeve will take the irrigation into the anterior chamber, and the tip, which will do the cutting part. So this is a basic anatomy of a tip, the shaft, the wrench. It is basically made up of a high quality stainless steel, or it could be titanium for a better durability and resistant to corrosion. It varies from 1.1 to 0.9 diameters, and these small variations are also very significant in cutting. The main importance of the tip comes while you're dealing with the dense cataracts, the design of the tip, and it also maximizes the fluid. So when we talk about the tip, there is a 0-degree tip, or it could be with a little bevel. So bevel could be from 15 degrees, 30 degrees, 45 to even 60 degrees. Larger the bevel, more the surface area. 0-degree tip will have the minimum surface area. Smaller surface area will cause maximum holding power because it's a smaller surface area. It will easily get occluded and create a better holding, immediate holding. But cutting is less in this because it is a, there is no blunt, it's a blunt edge. It's not a sharp edge. So there comes the requirement of an angled, the bevel surface of the tip. So we have to have a moderation of better holding as well as better cutting. So 30 to 45 degrees of a bevel will give you a moderation of both, a holding as well as cutting. This is a Phaco tip oscillations, the movement of the Phaco tip. So this is the traditional, the longitudinal Phaco motion which used to come in the initial times, the initial systems, which goes, I'll show it again. The traditional, the longitudinal motion which goes forward and backwards, the jack and hammer pattern. Then came the transverse pattern, which used to go sideways, left and right, continuous motion. And the third one is the combination of both the motion, which is torsional, the transverse as well as the longitudinal. So this gives you a benefit of both, which comes in a Ozil technology, which is a mixture of longitudinal as well as torsional movement, and an elliptical technology used in other machines, which is kind of similar. So what is the advantage of these motions? Longitudinal is a back and forth motion, it's a jack and hammer. It will come and go back. So it forces, it pushes the nucleus piece, which repulses over. So the energy is continuously liberated in going forward as well as backward. So there is a waste of energy when the movement is backwards. The energy is still being released, but there is no cutting motion in the coming back. So there came the transverse motion, which was sideways. So energy efficiently was used in this because cutting is continuously going on. There is no waste of energy, efficient use of energy, less heating problem, wound burn. And combining both the technologies helps in better cutting. Then came an advantage of an aspiration bypass system, which is a very small hole of 0.175 millimeter at the bevel at the shaft of the tip. It is a aspiration system. That means that there is a little bit of aspiration irrigation going on even when the tip is completely occluded. Like the irrigation is not completely stopped, as happens in a normal peristaltic system. So there is a gentle continuous flow. There is irrigation maintained in a small proportion. So cooling is continuously being done. Heating problem nahi aata hai. It is being replaced. Sudden surge nahi aata hai. And it reduces the decreased risk of thermal injury because of the use of aspiration bypass system. Then there are two kinds of tips. One is a straight tip. Other came as a Kelman tip, which is slightly bent 45 degrees along with the aspiration bypass system. It used to give a stroke length. Stroke length means the moment of the tip, of the length of the tip that it will go forward and backward, the amount it will, the distance it will cover. So it was 130 microns. To increase this came a balanced tip, which was a 2-bend tip. at a 45 degrees. It also comes with the aspiration bypass system, and the stroke length here is 192 micron, which is the highest. It gives a higher distance of cutting.
Use of ozal torsional energy on a straight tip results in a balanced displacement of
So this is the straight tip
energy
giving
from
a
the shaft.
longitudinal
The
as well as the
straight tip does not
torsional
affect
movement.
torsional
So
energy
here you can
since
see the
there's no
stroke
bend
length
in the
will be
distal
little
end of the tip,
lesser.
Therefore, no cutting efficiency. Use torsional energy on
When
the
came the
benefits in
Kelvin tip,
cutting
it
efficiency
increased
as a
the
result of
stroke
the
length.
bend.
It gave a better cutting.
However, the 20 or 12 degree bend could cause an unbalanced displacement of energy through the Intrepid balanced heat and move.
And this is the balance tip. This is giving longitudinal as well as the transport moment. This is the ozil technology.
The result is a tip
And a
with
better,
double bend that has a
this thing,
similar profile to a straight
better
tip.
stroke length
This allows
and less
surgeons to
thermal
maximize the
damage.
use of ozal torsional and have a more balanced distribution of energy through the shaft. Due
This
to
is
the
the
balanced
aspiration
tip
bypass
design,
system.
ultrasound energy is maximized at the distal end to give surgeons ultimate cutting efficiency with improved
Then other kinds of tips are the high vacuum tips, the Bezola trick. Here the main function comes from this occlusion and the center. It's a internal occlusion slightly. It reduces, it gives an early occlusion and faster vacuum. There is narrowing of the tip in the inner diameter. So you get best of both the worlds, early occlusion as well as less surge. It's in a hourglass pattern. Then also came a flare tips. It's a same kind of tip but little flared at the edge. So it gives a better holding and more stability of the anterior chamber. The other kind of tips are the coaxial and irrigation aspiration probes. There are kind of two types. One is coaxial, one is bimanual. In coaxial, we have got two ports, one for the aspiration, two for the irrigation, mostly placed at 90 degrees away from the aspiration ports and comes in 0.2 to 0.7 millimeters size. Bimanual will have two different probes, one for irrigation, one for aspiration. It's a perfectly closed system, so better stability. It prevents the prolapse. Third thing is the Phaco chopper. There are varieties of Phaco chopper that we keep seeing every now and this is a Nagahara chopper. It's a angulated one at 90 degrees and blunt at the tip. It's designed separately for left and right-handed surgeon. And it's slightly curved to prevent the posterior, it's not sharp, the curved edge is to prevent the posterior capsule rupture. Then is a Sybil nucleus chopper. Again, this has got a slightly curved edge with a cutting thing in the inside area, and it prevents posterior capsular rupture because of this rounded edges. There is a Agrawal chopper which has got a very sharp edge, 90 degrees angle. It's a reusable thing, comes in titanium, stainless steel, both autoclavable. There is a universal chopper, and then is a claw chopper. It's a quite big one, and it helps in cutting as well as preventing the posterior capsule rupture again here. There is a Kosh Minami chopper, which is designed to divide, dissect, as well as manipulate, and also preventing the capsule protector. That's it. Thank you.
Thank you so much, Dr. Urvija. That was a very nice presentation
Thank you so much,
giving a brief overview about the machine, needles, and the chopper.
Just few comments. Whenever the angle of tip is more, the cutting is better. So that means 45 degree, 60 degree tip, when you mark to make a trench, it will cut better. So for initially when it was a trenching base, so the tips were used 45 degree. But now it is more or less chopping based technology. 0 degree tip gives the maximum hold and easier to hold, not maximum hold, whereas occlusion is easy. 45 degree has a big oval, so a small matter cannot completely seal it, so you're not able to hold it. So holding is poor if the bevel is large, because the area is large. If you can completely seal it, hold will be better, but sealing it is difficult. And 0 degree tip gets hold very fast. When a small material, you can hold it and you can build up the vacuum. But 0 degree, because of the angulation, the lower part you are not able to see. Because tip is going like this, upper end you can see the lower end. So the universal tip now uses a 30 degree, which is the commonest and serves all the purposes. So all of us are using now 30 degree. So that, no, I think we will not discuss I will not discuss the chopping techniques, but of course, when your bevel is down, sealing is easy because the bevel is down and it can seal very comfortably when you are doing a direct chop. But at the same time, many of us don't feel comfortable when we don't see the tip. And another, whenever you use one is the conventional longitudinal energy delivery, and this is a non-conventional rotational or elliptical. The basic advantage is that heat generated is less when you use the non-conventional. When you use a to and fro movement, there is more heat generated. So wound burn chances are less. And secondly, repulsion of the material is less. When the nucleus when is stuck here, when this bombards, it may get repulsed. But when it is cutting like this, it will not get repulsed. So it sticks to the tip better and heat generation is less. And whenever hourglass tip or a flared tip is concerned, the surge depends upon the narrowest passes on whole of the channel. But hole depends upon the tip where you are grabbing it. So to decrease the surge, particularly in a venturi type of system, the front mouth they kept like a cobra so that you can hold it well, but then narrowed at the center, or they use another method so that the end of the tip is little smaller. So the surge will depend upon the narrowest passes, how fast the surge will happen, but the hold will on the, so that is the advantage of that.
Thank you so much, Dr. Urvija. Now I would like to invite Dr. Amrita Sahani, and she would be telling us about the power modulations. Dr. Amrita, I think your presentation is that side. Yeah. Over to you, Dr. Amrita.
Good afternoon, everyone. Thank you for joining us and thank you for the opportunity. So I will be talking about the power modulation in Phaco emulsification. So as we know that Phaco machine has a lot of functions and the interrelationships is called the Phaco dynamics. There are two main functions. One is the ultrasonic power, which I'm going to talk about today, and irrigation aspiration, which is a safe suction of the emulsified material. So I think Dr. Urvija has covered the piezoelectric quartz crystal which is present in the handpiece. So I won't be repeating that, basically converting the electrical energy into the ultrasound energy, and they're 2 to 4 in number. One thing I would like to mention here is that more the number of crystals, more is the stroke length. So that stroke length is basically the one which actually tells us how much power is going to be delivered. But we still say that these number of crystals, so suppose like we said 2 to 6 crystals are present in the handpiece. So more number of crystals, they will give you more stroke length, so the more power will be generated. Now the difference is in the frequency as well. So these crystals, they move at a certain frequency which can range between 29 to 60 hertz, but each machine has a fixed frequency. Now more is the frequency, better is the cutting action, but more is the heat generated, but ultimately the surgical outcome is not affected. So all the machines, they have a fixed frequency, so the power completely depends on the stroke length of the phaco tip. The advantages of this system is high efficiency, in little heat generation and no extra cooling is required. But there is also a disadvantage to the piezoelectric crystals is the inherent brittleness of the crystal itself. So the longevity of the transducer is affected, and there are a lot of connections between the piezoelectric crystals, so the whole system is quite complicated. Now, more importantly, we need to know how the phaco power is being delivered with the foot pedal positions. So we have two dentitions. This is common to all the foot pedals, most of them. Apart from the dual system, I'm going to talk about the general system. So there are two dentitions, D1 and D2, and 3 excursions. So when we go to the first excursion, it is irrigation on, the pinch valve opens. So irrigation is either fully on or fully off. There is no gradient there. Then we cross the dentation 1 and we go on to the excursion 2, where irrigation and aspiration both are on. Then we cross the dentation 2 and we go to the third mode, where the irrigation is on, aspiration is at the maximum precept value, and the phaco power will be depending upon how much of the foot pedal you are pressing. Now this is about pressing the foot pedal. When you're going back, you go to D2 and then you go back to D1. Now this is important because you need to stop at D1. It is at this point that the irrigation will be maintained and anterior chamber will not collapse. This is very important when you are manipulating the nucleus, especially during step 1 and step 2 of phaco emulsification. Now, another important thing is reflux, that is a sidekick. So suppose you have gone and wrongly picked up the capsule or some kind of iris, and you want to kind of expel it back into the anterior chamber. So you just give a reflux, the sidekick. We must remember that it is not a continuous mode. So every time you want to reflux the tissue or you want to do it again, you have to kick it, put the reflux mode again. So So before attempting Phaco, even for the trainees, it is very important. They must know about the tactile feedback, that is the depressions while going down and while going up. And secondly is the auditory feedback, which is aspiration feedback. What is the auditory feedback when the Phaco emulsification has started? Now we need to know that how much of the power will be generated with every excursion of the foot pedal, that how much of the foot pedal you press and how much of the power will be generated. Now this actually depends on two things. How much is the distance? So suppose the IAP 0 means the Phaco energy is 0 and IAP max means the Phaco energy maximum. Now the distance between these 2 points, suppose it is 100 millimeter and the maximum power that you have set on the console is 100%. Then it means when you press 100 millimeter, 100% of the power will come, which means 1 unit power will be generated when you press the foot pedal 1 millimeter. Now suppose you reduce this Phaco power on the console to 50%. That will mean that 2 millimeter of the excursion of the foot pedal will give you 1 unit power. And similarly, if you reduce the Phaco power further to 25%, it will mean that 1 unit of the power will be generated when 4 millimeter of the foot pedal excursion has been done. So when you decrease the preset value of the power on the console, it increases the foot gradient. That means more of the foot pedal has to be pressed to generate equal amount of the power. Therefore, the foot control becomes better. Hence, it is very important that the Phaco maximum should be set at the minimum possible level which is required for a particular grade of the nucleus. So we can say that for trenching, we need more Phaco power as compared to Phaco aspiration, and it is even lesser required in epinuclear plates. So it is very important to know. You have to tell your assistant, and even you should check yourself how much of the Phaco power you have set on the machine. You can even feed them in the newer machines. So basically, there are two mechanisms how emulsification happens. One is jackhammer effect, that is a bombarding action of the tip. So it is a rapid to and fro movement of the tip, like we can see in this diagram here, which kind of disintegrates the nucleus. And the second phenomena is a cavitation phenomena. Cavitation phenomena means that there is a rapid backward movement of the tip. Now the tip moves faster than the fluid which is surrounding the tip. So it creates a kind of a bubble there, a hole, and the fluid fills into that bubble and it kind of causes emulsification of the tissues. Now jackhammer effect, as we know, it depends on the contact of the tip and the nucleus. So it becomes very important that the hold is good. Only then the jackhammer effect functions. And the force with which the tip actually strikes the nucleus is given by the formula mass of the needle, which is fixed for us, and acceleration. Now, acceleration is further given by stroke length into frequency, and as I mentioned earlier, frequency is fixed again. So the whole thing is completely dependent upon stroke length, so power is directly proportional to the stroke length. So this is how important the stroke length is. And cavitation, like I explained, that the fluid falls into the space that is created. It is better explained with this diagram, that whenever you are pressing the foot pedal, you are giving certain amount of ultrasound power. So this gives wave fronts of expansion and compression. That creates an area of high temperature and low pressure, and the whole system collapses within that cavity. Now the forward movement of the tip also gives an acoustic wave. So like in jackhammer effect, it pushes the nucleus away. So if your vacuum built up is not good, it will actually go against the jackhammer effect and the nucleus piece will be pushed away. But if your hold is good, then it will also affect the jackhammer effect. So we have to really look at the vacuum in every stage of Phaco emulsification that we do. Now cavitation, when I say, it should not be confused with the air bubbles that we all experience. Sometimes they come in the anterior chamber. They are just the air which comes out of the solution in the anterior chamber or gets sucked into the system from outside. There are other terminologies like chatter. They are just the movements of the nuclear fragments. And sweet spot is one of the terminologies which is used. It's the exact point at the foot pedal where the nucleus piece can be easily attracted and can be emulsified. Now coming to the Phaco modes, this is a very important topic. There are mainly two modes, the surgeon mode or the linear mode, and the second is the panel mode or the constant mode. Now what is the surgeon mode or linear mode? It means that it will depend on the amount of foot pedal that you press, like I explained before. So power delivery is from 0 to the maximum power that is set on the console. But it will entirely depend upon the foot pedal, how much of the foot pedal excursion is there. Suppose 1 millimeter, then how much 1 millimeter is giving, 2 millimeter, how much 2 millimeter is giving. Whereas in panel or constant mode, as soon as you go to the Phaco mode, a full power will be delivered into the eye, which means that there is no variation here. The full power is delivered whenever you go to the Phaco mode. Most of the surgeons, they prefer the linear mode so that they can have a better control. Whereas the only probable indication for the panel mode or the constant mode is where the nucleus is extremely hard and you know that it's uniformly hard and you need uniform energy. You can specially use it in cases like direct chop. Now there are other modes like pulse mode. I'm sure you must have heard about these modes. So pulse mode means each pulse of energy is followed by a gap. So the duration of the pulse that comes into the eye is equal to the gap that we give. Now this gap is very important because it helps in the vacuum buildup. Hence, pulse mode is a variant of linear mode where the frequency of pulses and the duration of pulses is fixed, but what amount of power will be delivered in that particular pulse will actually depend upon how much of the foot pedal you press. So we can see with the help of this example here. So this is the Phaco on, this is Phaco off. So this is a pulse and this is pulse off time. If you see, the foot pedal is here somewhere in the midway. So half of the power is being delivered. When the foot pedal is fully pressed, then full power is delivered. Suppose there's 50% power on the console, then when you press the foot pedal, 50% of the power, the whole of the power will be delivered. But the gap between the pulses is the same, so the frequency and duration of the pulse remains the same in the pulse mode. Whereas there is a modification to this. So on and off time is the same and it is really helpful in stop and chop technique. So the modification is a hyperpulse mode. So hyperpulse mode means a bundle of pulses are clubbed together and then there is a gap between these bundles. Now the catch point is, I'll explain with the help of this diagram here. So this is one bundle. So these are different pulses in one bundle. The on and off time between these pulses, within this bundle will be the same, but we can vary the time between the bundles, between the two bundles. Now you see in this example, this is one bundle, this is second bundle, but the time gap between all of them is equal. And again, this is based on linear also. So if your foot pedal is here, it is half of the Phaco which is delivered in each bundle. When your foot pedal is fully pressed, the Phaco which is delivered is the full power Phaco is delivered as per the console. Now in this is a second example of hyperpulse mode where this is one bundle and the gap between the pulses is the same, but gap between the bundle has been increased. Now the advantage over here is a duty cycle. Duty cycle is basically Phaco on time divided by Phaco on plus off time. Now we can make use of this off period because this helps in cooling and lesser damage to the eye, lesser heat generation. So in first example, like we can see, it is 100 because this and this is equal. So it is 100 divided by 200, so duty cycle is half. Whereas in the second example, this is one bundle and then there is a gap of 900 milliseconds and then another bundle. So it becomes 100 by 1000, so almost 1 by 10. So it helps in reducing the heat generation. And burst mode is same as a constant mode where the energy is fixed. So if you see the foot pedal here, even when the foot pedal is here, you have maximum energy. And when the foot pedal is down, you have maximum energy which is delivered. The only difference is the frequency increases. So in the burst mode, when you press the foot pedal, it is the frequency increasing, but the power delivered will be the same. It is very useful in dense nuclei. Now, I think types of phacoemulsifications are very well covered by Dr. Urvija, and she's explained everything in this. The only thing I would like to say is, like Dr. Lal also mentioned, when you angulate the tip, the cutting becomes better. But the catch point here is, when there's an angulation, like Kelman tip, the tip which is below is quite angulated, so it can actually damage the posterior capsule. It can cause posterior capsular tear. So they brought about a modification which is called the balance tip, which again Dr. Urvija showed that it's forward angulated, so it's safer. Secondly, why angulation helps is because this is the base. Over here, the movement is less as compared to the tip. So when the tip is moving, the cutting is efficient, but at the same time, the heat generation, which is near the wound, that is less. Because this base is moving less, the tip is moving more. That is the advantage of angulation. That is how angulated tip came into play. This has been explained. Sir, do you want me to cover nucleotomy or should I stop?
We will talk about the power settings only.
Power settings only.
Related to the power mode.
Okay. So the purpose of nucleotomy is basically the central core of the nucleus is to be eaten up piece by piece without damaging the cornea and the posterior capsule, and the most common methods are divide and conquer and chopping methods, or a combination of two. Nowadays we are using stop and chop, where we start the trench, the first trench like divide and conquer, but we stop there, we rotate the nucleus and we start kind of chopping the different chopping techniques. And another important thing we need to know about is the central safe zone. It is the area which is vertically bounded by, on the top by cornea and with the posterior capsule behind. The maximum space in the anterior chamber is in the central safe zone. We should get the nucleus piece and the cortical matter into the central safe zone before we emulsify them. It is more in cases of myope, zonular stress syndromes, and vitrectomized eyes, and they are smaller in hypermetrope, small pupil, and smaller X's. The peripheral unsafe zones are capillary fornices and angle region. We should avoid doing emulsification over there. Now, trenching is the most important step. It involves making a groove in the nucleus. This step is vital for stop and chop and divide and conquer techniques, and this should be performed under low vacuum settings because here we do not want to hold the nucleus. Now, the ideal power, how will we select the power in such cases? So, it should be an ideal power where there is no wastage of energy and no movement of the nucleus. So, a rough estimate is grade of the nucleus into 15 plus 25 is what you can set for trenching. And linear mode is preferable when you are trenching. Now, how will you know whether you're wasting too much of energy? So, if there are bubbles which are coming in the anterior chamber, it means that you are giving too much of energy and there's really nothing to emulsify. And at the same time, if you're giving too less power, which is required, suppose there is a grade 4 and you're just giving very low power, you'll keep pushing the nucleus, and then that will cause zonular stress. So that is why there's an ideal formula. You can select it as per your needs, but that is the formula, grade of the nucleus into 15 plus 25. Now, length of the trench ideally should be within the capsular rex's margin. In case of really hard cataracts or very soft cataracts, you can go under the capsular rex's and you can go to the delineation margin where it is called relaxing nucleotomy. And when you want to widen it, like Dr. Lal said, we feel a bit unsafe if we are not able to see the tip. So it is better to keep the bevel up and then just widen it like this. On two sides, it should be ideally should be 2 dip diameters so that the sleeve doesn't get stuck into the trench. And then shaving, so how do you do it? So the best way is the tip should keep moving, should be up like this. It should keep moving like this, and the handle should be using the incision as a fulcrum. And once the superficial trench has been made and you've kind of widened it, then you go to the deeper trench. So then
the setting, how the settings different are different in a trenching, chopping, and Phaco aspiration.
yes. So
So in a power setting, because the aspiration will be covered by, so how the power setting will vary when you make a trench, and what your power setting will be when you are, how you vary your power setting in a trenching, chopping, and when after chopping you are doing the Phaco aspiration.
yes. So, like I mentioned before, roughly the power settings is maximum when we are trenching because, and the vacuum is low, vacuum will be covered by ma'am. So, when we are trenching, the rough formula I've given, grade of nucleus into 15 plus 25, that could be during the trenching. Once you've trenched, you crack the nucleus and then you rotate it. So, once you crack the nucleus, then you rotate. And once you have the 2 heminucleus, you start chopping them. Now, there are different ways of chopping, the horizontal chopping, the vertical chopping. And the power setting doesn't really vary in horizontal and vertical chopping. But in case you're doing a direct chop, in that case, you can have high power settings. Then, depending upon the grade of the nucleus. So, suppose you're doing stop and chop in a soft nucleus, you can keep the power setting as low as compared to what you use it in trench. But in cases of hard cataract, you can use a higher power setting, and you can also use different modes. So, basically, if you have a good knowledge of the anatomy of the nucleus, the instruments and machines, and the basic hand motions, you can even make the complicated procedure rather easy. Thank you.
Thank you, Amrita. I think basically when you are trenching, you can have a continuous mode. You don't have to have a pulse mode because it's a continuous process going on. And at the trenching time, you can have a high power setting as compared to when you are doing the nucleotomy. So because you want to make a trench. And at the time of trench, you are absolutely calm and quiet, and you can vary the energy level depending upon the density of the nucleus. But when you are chopping, probably you are more stuck. So while chopping, you need a little less Phaco energy, and a pulse mode is better at that time. And for Phaco aspiration, you can further lower the energy. Like suppose if you are using, depending upon the machine, 40% for the trenching, you can use 30% for chopping, maybe 25% for Phaco aspiration. So as you keep on going up, the power can be reduced, and the pulse mode is needed when you are doing the chopping and aspiration. But trenching you can do in a continuous mode.
Depends upon the beginner. Surgeon is a beginner or a very proficient surgeon, so we can change, like pulse mode is more safer, and on the burst mode, more experienced surgeons, they can go on to the burst mode. So the beginners should not try too much of the burst mode. Yeah.
So now I'll invite Dr. Parul Singh. She is Associate Professor at Kanpur. She'll be talking about the most important aspect of this Phaco dynamics, that is the aspiration. Because now the machines, initial machines, the basic machines were more of a energy based. When we started learning, the maximum vacuum we could set on a machine was 120 or something. And that was the reason we used to have more wound burn. The energy was used at 100%. And in fact, when I was starting learning, I mean, the cutoff time was 3 minutes of Phaco time, 1.5 minutes of Phaco time. So now which has reduced to few seconds. So the aspiration has improved over a period of time. So the fluidics is the most important part of understanding this machine.
Thank you, sir. Thank you so much for the opportunity, sir. So I would be talking about the fluidics part of the Phaco dynamics and how we have to control the surge. So what is fluidics? Fluidics is basically an integrated function of infusion and aspiration of the fluid. And the advantage of Phaco emulsification over the previous conventional surgery is basically that Phaco is a closed chamber surgery. So it is the understanding of the fluidics that basically helps us to maneuver through the normal Phaco and also the difficult and the complicated situations in the Phaco emulsification. So to understand fluidics, the basic factors, so basically the fluidics means whatever is inflowing, that is the infusion, the fluid that is coming into the interior chamber, and the outflow, that is the fluid that is exiting the eye, the anterior chamber. Now this inflow will be through the bottle, the fluid is coming, and outflow will be through either the normal outgoing, that is through the tip, or through the wounds which we have created in the form of main ports and side ports. Now through tip, the outflow of the fluid will depend upon 3 factors which we will discuss subsequently. One is the vacuum, which is the holding power. One is the flow rate, that is how fast things happen in the anterior chamber, the fluid leaving. And another thing will be the compliance of the tubings. So first talking about the inflow, we just said that inflow, basically the fluid infusion is coming through the bottle, and height of this bottle basically determines the gradient of the flow. So this infusion is gravity dependent. For example, a 2 centimeter bottle height would result in around 44 millimeters of mercury. Similarly, 100 centimeters would cause a 74 millimeter of mercury in the IOP. So safe height somehow lies between 60 to 90 centimeter, or we can say 3 plus minus 1 feet. Now, the amount of fluid which is entering, if we increase the amount of fluid which is entering the eye, it will raise the intraocular pressure. So the bottle height has to be adjusted in such a safe way that the IOP is also at the safe level and we have a stable anterior chamber. So if we have increased the height too much, what it will cause, it will basically stretch the zonules and the patient will feel the discomfort because of too much rise of the intraocular pressure. If the IOP is too much, so a slight withdrawal of the fluid will cause very high IOP fluctuations, which is again not a good idea for the tissues. Another thing is, if there is a lot of fluctuation in the iris because of a lot of fluid coming, it can lead to meiosis and the pupil will become small and the surgery will become difficult subsequently. Also, if too much fluid is coming and we have larger wounds, if we do not have a very good wound construction, it might lead to repeated iris prolapse. So that is what we have to understand when we keep a bottle height. Now, the another thing, now we have discussed the inflow. Now, the main thing, the aspiration system is the main part of the Phaco dynamics here. So, as we discussed, it will be vacuum, it will be flow rate, and subsequently we'll discuss compliance and followability, etc. So, first to talk about vacuum, what is vacuum? Vacuum basically is the holding power and it is generated by the machine. So, vacuum is the measure of the strength of the hold of handpiece over the nucleus. So vacuum is basically a double-edged sword, and why do I say so? Because the settings of vacuum basically we have to keep changing, and what setting, how much vacuum to be used where. For example, if we are holding nucleus, or we are holding cortex. So the settings of the vacuum will change. We would need more vacuum to hold on to the nucleus than to the cortex. Similarly, the vacuum is being transmitted either through the phaco tip or it is being transmitted through the inspiration-expiration cannula. So, so this is how we have to understand when to use how much vacuum. Now coming to flow rate. Now what is flow rate? Flow rate, the term means the amount of fluid which moves out from the eye per minute. So flow rate basically determines how fast the things will happen in the anterior chamber. So it is very important to have a good understanding of the flow rate. But to understand, flow rate is basically for peristaltic pumps, the flow pumps, and not for the venturi, because in venturi it is the part of vacuum itself. So in peristaltic pumps, as we have discussed earlier in the talk, so the flow rate is basically a determining factor in peristaltic pumps. Now flow rate is set for standard tips and tubings and fluids. For example, if we have a small bore tip, so the flow rate will be less because less amount of fluid will go out of the eye. Similarly, if lens matter is coming out or the viscoelastics is coming out through the tip, so the flow rate will be less effectively. Similarly, if we have less elastic tubings, the flow rate will be less. So in earlier machines, the vacuum was only up to 120, and gradually when the machine generation improved and we had better settings and better dynamics, so the machines from first, second, third, fourth generation, the vacuum increased from 120. Now we are operating at more than 450 millimeters of mercury also. Similarly, flow rate in the earlier machines was only up to 20 to 24, and gradually with the advent of modernization of the phaco dynamics, the flow rate has now increased from 30, 36, and even now we are working on 40 cc of fluid as flow rate. Now there's a term called rise time. What is rise time? Rise time is basically the time which is taken to reach a preset maximum vacuum after occlusion of the suction port. So if you see in this figure, in the venturi machines, if you see, there's a sharp, fast and linear, and because what is happening, venturi machine only it is the vacuum, so the vacuum is directly there on the tip all the time. So the rise time, that is a time to reach the preset vacuum, is short, and it is fast and it is linear. But in peristaltic machines, reaching a rise time, it depends upon the flow rate, because flow rate basically decides in the peristaltic machine that how things will happen. As you see, P1, P2, so P2 the flow rate is higher, so we get a sharper curve and the rise time we reach earlier. So higher the flow rate, earlier we reach the rise time. Aspiration systems have been covered, which are like venturi and peristaltic. We have discussed venturi is based on Bernoulli's principle, where a compressed gas creates a negative suction in the cassette and that is transmitted to the tip. But in venturi, we can control the vacuum, that is we can increase or decrease the vacuum, but flow rate is proportionate to vacuum. It's a fixed fraction of the vacuum. We cannot independently set flow rate and vacuum in venturi pumps. Peristaltic pumps we have discussed, basically silicon tubing rolls over the wheels, negative pressure is created by squeezing of this fluid, faster the rollers rotate, more fluid is withdrawn and therefore higher the flow rates. That is how, what I was talking before, the flow rate is basically function of the peristaltic pumps. So in peristaltic pumps, vacuum is used to hold the lens material, and it is the flow rate is basically, flow rate determines followability and rise time. And what is followability? We'll just discuss in the next slide. So it's important to understand followability. So followability is a term which tells us about the tendency of the nuclear material to come into the tip. And so how does it happen? So as we know, that is infusion, when the fluid is coming, the fluid coming inside the eye, it causes a positive pressure. The fluid that is going out through aspiration, it creates a negative pressure. Now this gradient bit of pressure which happens between positive and negative pressure, it creates a pressure gradient, and this pressure gradient, they form certain eddy currents in front of the tip. Now when this eddy currents, they help the nuclear fragments or whatever is there, everything that comes near the tip, and that helps, right? So in this picture, if you see, there is a green area near the Phaco tip. This is the area of good followability, right? So in this, whatever will be in this area, that will easily come through the tip, a good area of very good followability. Now if you see the area of main port and the side port, which is shaded gray, this is the zone of no followability, because whatever, if a small piece gets stuck in these ports, it will not come itself. We'll have to maneuver it through the second instrument. And the green area you see in between, that is the zone of poor followability. So in that area, we can shift our Phaco tip handpiece and we can bring out the pieces. So in nutshell, in the followability in venturi system, since the vacuum is generated even without occlusion, so the pressure gradient is high, followability is very good in the venturi system. Now in comparison, in the peristaltic pump, since there is no negative pressure at the tip until occlusion happens, the gradient of the pressure is poor, so the followability is relatively poor as compared to the venturi pumps. But if we increase the flow rate, the followability can be improved, right? So to have a better, what we do, size of nuclear pieces we always divide nuclear pieces into small pieces. Now these small pieces will have better followability. So this emphasizes why we should make into small pieces before we suck them. So, and I've already discussed, if the pieces are lodged in the angle or the capsular furnaces or in the main port and the side port, these are the areas of the poor followability. So this was about the fluidics. Now another part of this presentation is about the surge. So to understand what is surge is basically sudden withdrawal of fluid from the interior chamber. So a certain amount of surge is okay, but if that surge increases beyond a particular limit, it will cause the collapse of the anterior chamber. And we do not want the collapse of the anterior chamber because it will be detrimental to the structures inside, iris, cornea, PC. So basically, it is the modification in surge control which has taken Phaco to where it is today, a better and a safe surgery. So if there would have been no surge, anybody could have mastered the Phaco emulsification. So basically it is a surge control which is now so good in the machines and also as the surgeon experiences. Now the surge basically depends upon the two things, and we'll understand in the next slides about compliance and hysteresis of the system. What is compliance? Compliance is basically the property of the tubings to collapse, that is deform under pressure. So the extent of collapse will depend on three things. One is the size of the lumen of the tubings, one is vacuum, and one is the thickness of the tube. So the lumen size, if the size is more, so the compliance will be more. If the vacuum will be more, the compliance will be more. But if the walls are thick, the compliance will be less, right? And what is hysteresis? The hysteresis is the term which is used. It is a speed with which the collapsed tube regain their normal shape. So the regaining of the normal shape of the tubings, it depends upon the hysteresis of the material. So higher hysteresis means slower the speed of reformation and less the surge. So this is the concept of compliance and hysteresis which we should know before we understand surge. So in this diagram I'm just explaining, as you see in picture, the first, you have a piece and we have this peristaltic pump rolling. When you see in the second, when we come down, there is occlusion at the tip. So when there is occlusion, the vacuum will build up, the rollers will stop moving, and there will be development of the negative pressure in the tube, and the tubes will collapse, right? Now, subsequently, when the occlusion will break, there will be release of the negative pressure. The tubing will re-expand to its original size, fluid will be withdrawn from the anterior chamber, and surge will happen. So this is how surge happens in the anterior chamber. So the basic thing now basically is to understand how we can control this surge. Controlling surge is all we want to do when we want to do a safe Phaco emulsification. So there's two ways to control surge. One is by the machine, all the modifications and advancement in the machine, and another thing is how the surgeon can control the surge. So we'll take one by one how the machine will prevent the surge. So the first thing, which was earlier in the machine, the one process is venting. So as you see in this picture, we have a piece, then we have a peristaltic pump, and you see a valve. So right now, nothing is happening here. Now, you see when there is occlusion of the tip, the tubing has collapsed, and we can see the vent is still closed. Now what happens subsequently, when the occlusion will break, the tube will expand, and now you see the vent is open. So what this vent is doing, it is supplementing extra fluid to the system. So there is a sensor in the machine, so when the occlusion happens, the machine senses that there is occlusion, and the vent will itself, this valve will open, it will gush amount of fluid, the extra fluid. Now this extra fluid will take care, and there will be no collapse of the anterior chamber, and so we will have minimal or no surge. So this is the process of venting which machine uses to prevent surge. Other thing is, when we deal with tubings, modifications we can do at the level of the tubings is, we can use a large diameter tubing for irrigation, and we can use a small diameter, thick and hard walled, that is a high vacuum tubings for aspiration. So the use of these tubings will definitely reduce the surge. And now, as we know, in modern machine, after third generation Phaco machines, the tubings have been replaced by the cassette, which is again the machine that's how controls the surge. Now another modification, the machine came by the Star Surgical in the form of cruise control. Now in cruise control, what happens, this is basically we are improving the aspiration system. What we do in this, that we basically limit the exit of the fluid. How? There is near the aspiration tubing, we have a fluid restrictive exit after a cylindrical mesh, which restricts the exit of fluid without affecting the removal of the cataractous material. So in this way, less amount of fluid is released, so the machine has smartly controlled the exit of fluid and has very smartly controlled the surge. Now next modification came by the White Star, which is caused the chamber stabilization environment case. So what happens in this, the machine, when occlusion happens, the machine senses this, and it decreases the vacuum. The machine senses that the occlusion has occurred. So what happens is, the Phaco power, which is activated to occlusion mode setting, and then it defaults back to unoccluded mode settings, and there will be a down threshold of the vacuum, and so there would be limitation of the surge. Now so basically case technology allows the surgeon to operate in a new performance zone while they only break occlusion from within the comfort zone. Next came the advancement of active fluidics in the Centurion system by the Alcon. So again, they have dual sensor in irrigation as well as aspiration, so have a definite advantage over the gravity-based fluidics which was used in the previous machine of Infinity. So what happens in Centurion? The machine senses, it steps down on the vacuum before the occlusion breaks. So this active fluidics, this fusion fluidics, it maintains the interocular chamber, improves the chamber stability by control of the target intraocular pressure. So it is a very, very safe system which has been developed in the Centurion, and it takes care of the surge. We almost have no surge in these advanced machines. So this was how the machine will control the surge. Now we will discuss what the surgeon can do to control the surge. So what is in our control as a surgeon is, first is the infusion. So we can increase the fluid into the anterior chamber. How? We can increase the bottle height. We can use the TER set, the improved tubing sets. Then we can use the anterior chamber maintainer if we wish to, or we can do the surgery in continuous infusion mode. So this is how, with the help of the infusion, we can control the surge. Now second thing to control the surge is to make a very good wound. So wound construction is of paramount importance in the beginning of the surgery. Both main ports and side ports. So main port, it should not be too tight. Or what will a too tight main port do? It will restrict the amount of fluid also. So it will somehow restrict the good inflow of the fluid. It shouldn't be too loose. It shouldn't be a premature entry. Too loose main ports and side modes will leak will cause a lot of wound leak. It is not a good idea. It will augment the surge. Similarly, premature entries, it it creates a lot of problem, lot of fluid leaks. Every time we enter and exit with the help of our handpiece, lot of fluid is withdrawn, and so it causes surge. So adequate wound construction is of paramount importance. When it is in our hands to make a good wound, less surge. Now the third thing in surges control is to decrease the effective flow rate. So how can we decrease the flow rate effectively? First thing, we can use a micro tip. A small bore tip means less amount of fluid withdrawn, which means we can keep the flow rate lower. So lower flow rate, less fluid withdrawn, less surge. Similarly, we can increase the viscoelastics in the interior chamber while using our steps. Increased viscosity, because of increased viscoelastic, it decreases the effective flow rate. Similarly, the third thing which we can learn, which we do, is the partial occlusion of the tip. What does that mean? When we have occluded the tip with a piece, before we take it up by, and this is in our foot control. So before we remove this occlusion, what we can do is very swiftly, we can partially occlude the tip with another piece. So we are not breaking, after occlusion, we are not breaking this cycle, and before the occlusion breaks, we are partially occluding the tip with another piece. So this is how we can effectively decrease the flow rate. So basically, all this happens when we have a good foot control. So as the experience comes, the proficiency of Phaco, we learn. So basically, it is a foot control. So when we have a good foot control, we can maneuver all this, where to keep the foot before the occlusion breaks, and how we can control this. So this is all I have to tell about fluidics and surge control. Thank you so much.
Thank you, Parul, for a wonderful presentation. Now I'll be talking about parameters modification in different and difficult situations. So this is a video of a hard cataract. So if you see this, we have made a good trench. And I have not done hydro before making the trench, because when you do the hydro, the nucleus starts rotating, and this keeps on pushing. So now after making 90% of the trench, I do the hydro. And once we do the Phaco emulsification, we are trying to crack this nucleus. So nucleus is separated, but the leathery plate which is behind does not allow it to really get completely separated. If the nucleus is not separated in two, it's very, very difficult to complete the chopping. So what I'm going to do is, I'm holding one edge of the nucleus with a maximum vacuum of 600. At this time, there is no chance of PC coming anywhere near. And now, the nucleus gets lifted up, 600, 650, whatever your machine permits, and then you do the sideways separation instead of pulling all the fibers together. So that means when you are trying to separate it, whole of the nucleus inside, there is no danger of PC coming up. So keep the vacuum as high as possible for a very hard cataract, otherwise you will not be able to break it. And even in this situation, when most of the nucleus is inside, the PC will not be able to come, so you can go on to the hard cataract. But when it comes to the last fragment, you see my chopper has been removed, I put the viscoelastic inside, I reduce the vacuum to 400, because this is the time of danger when the posterior capsule comes up. So you have got to control your parameters depending upon the stage you are. So when you're doing a hard nucleus, use the regular tip. Chopping vacuum should be 600. While you are doing aspiration deep AC, no change. That also will depend when you are doing the nucleus aspiration. If the chamber is deep, there is nothing to worry. But if the normal chamber, you can have a 500. If it is shallow chamber, hypermetropic eye, probably 400. So depending upon the chamber depth, depending upon the type of cataract, you need to modify your parameters. Even if it is a hard cataract, and the chamber is shallow. If this is a myopic patient, there is a deep chamber, you can go and keep on operating at 600, there is no problem. And near the end of the surgery, when there is nothing in the capsular bag, then there is high chances of capsule coming up. So put on a viscoelastic and lower the parameters. So this is an unstable nucleus. So if the nucleus is unstable, then making trench is very, very difficult. So you have got to use comparatively very high settings, maybe 600 or so. So, and I'm making just a small depression at the top so that I can bury into the core of the nucleus. You can do the direct chopping, but at that time, sometimes it does not go into the depth of the nucleus. So, after making a small depression, then I can go deeper into the nucleus. And this time, the vacuum settings are very high. I may do the central chop and split. So, at this stage also, there is no danger of the surge because the tip is completely occluded. Nothing is getting surged. The chamber will not collapse. PC is not there. So, don't have to worry about the vacuum at this stage of the surgery because there is no chance of the surge. But as the pieces keep on getting removed, when you are aspirating, then there are chances of surge. While you are doing the chopping, there is no chance of surge because the tip is already buried into the nucleus fragment. Again, when you come to the last fragment, you have got to lower the parameters, keep your chopper on the top to avoid touching it to the cornea, and go ahead and do it. So last fragment I already explained. So when you are doing the last fragment, put on a viscoelastic, remove the chopper, and lower the parameter settings. And you can change the chopper, which was sharp and long, to a smaller and a blunt chopper. In a soft cataract, on the other hand, if it is a young patient with hardly any nucleus, you can do it with the IA. But the vacuum settings should be on the lower side because the vacuum settings are high. The nucleus gets sucked in without, you are not able to hold it, and you go into the periphery, try to hold it, it gets sucked, and you have a PCR then and there. So vacuum setting and the power setting should be lower in a softer cataract. Whatever you think, even the power setting is low, there is no problem. In a harder cataract, should be on the higher side so that you just do not bombard it, chattering of the nucleus, and you can really bury it and emulsify it. But on a softer cataract, it should be on the lower side so that you don't have the suck-in of the nucleus. So in this case, like this is very soft cataract. So what we are doing is, just with the vacuum of 100, removing the rim of the EP nucleus between the anterior capsule and the anterior surface of the nucleus up to the delineation line. Because when you're trying to pull out the soft cataract, the anterior EP nucleus plate keeps on holding because your vacuum settings are low. If you keep a higher vacuum settings, it gets sucked in. And once this part of the epinuclear rim is removed, then this nucleus becomes very loose. Now you want to divide it, you divide it. If you don't want to divide it, you completely lift the nucleus out of the rhexis margin and can emulsify. So in a softer cataract, if you remove the rim of the EP nucleus between the anterior capsule and anterior surface up to the delineation line, then it is possible to do the surgery on a low vacuum setting. So you can see that this nucleus falls back nicely without any problem. So power setting in a softer cataract less than what you think is needed to avoid sucking in, and a harder cataract more than what you think is needed. In a shallow AC, we need to do the hypovolumic Phaco. That means there is a low bottle height and a low vacuum and a flow rate setting. Everything is on the lower side, easy going. If the deep AC, myopes, victimized eyes, jonulopathy where the chamber is deep, you can keep the bottle height low, but you don't have to lower the vacuum settings because there's enough of fluid inside the eye. So go on with your regular parameter. This is now the patient who had a phacomorphic glaucoma. So this is a very shallow chamber. So you can see that even putting the air is very difficult, hardly we are able to put it. And in this case, we keep the bottle height normal. You don't have to increase the bottle height because there is no space to take up that much of fluid. But the parameter settings are kept low. Power is kept high. Whenever if you see there are two things to suck in. One is the fluidics, another is the power. If you have got to operate on a lower fluidics, do not lower the power so much, then you won't be able to crush it very easily and suck it out. So hypovolumic is low bottle height and low fluidics parameter. Now this is when the iris prolapse is taking place, and if you are at the end of the surgery, you don't have to worry about it because whole of the nucleus has been removed now, so you don't have to do much. It was little premature entry, and that's the reason of the thing. Otherwise, you should lower all the parameters, and you should deposit this iris preferably from the, not from the same port, but you should go from the other side and deposit it. And now the mistake over here is being done is the viscoelastic is being injected too much, so it will try to leak out. You should not inject the viscoelastic too much if the iris is prolapsing. You should go from the side port and pull the iris in. So in this case, iris was small, was floppy. So instead of struggling and keep on lowering the parameters and iris gets sucked, it's better to use the dilating device and do the surgery comfortably. Particularly if the cataract is hard, the pupil is borderline, you feel uncomfortable, it is better to enlarge the pupil and then go ahead with your normal parameters. Sometimes there may be ergonomic situation, like this patient was in this situation only, and she could not be straightened up. So the incision was lower temporal, patient had a small pupil, malignant ring was placed. So the bottle height is normal, but my parameter settings are low. I'm operating standing so that I do not get the surge. So if there is a rhexis margin tear or descemet tear, uncooperative patient, poor visibility, spine and neck issues, any other problem, but the iris is not prolapsing, you can keep the bottle height good, normal, but lower your suction parameters if you're feeling uncomfortable and slow down your surgery. To sum up, hypovolumic, bottle height and fluidics parameters are low in cases of posterior capsular tear, iris prolapse, shallow AC, Ephes syndrome. Hypervolumic, bottle height and fluidics parameters are high in a hard cataract, unstable nucleus, and you need to use the high power. When you are in a hurry, some of the super fast surgeons can keep, like Dr. Kumar is sitting over here, all the time, high parameters irrespective of the stage of the surgery. But it may not be very safe for most of the surgeons. So customizing setting, what and when, that depends upon the space available in the eye, size of the pupil and capsular axis, endothelial cell count and a corneal clarity, floppiness of the iris, capsule and zonules, density of the nucleus, PCT, RMT, iris prolapse, whether you are doing topical, whether you have given a block, whether the patient is cooperative or not, and how is the palpebral aperture, that can make a difference to your surgery because there is a pooling of the fluid over there, neck and spine issues, stage of the surgery you are, trenching and chopping, and what type of technique you are using, what types of tips you are using, aspiration of the nucleus, epinucleus, cortex, viscoelastic. So it's a power setting is a dynamic process depending upon each and individual patient overall. Slow down if you are not feeling great today. Sometimes there may not be good days. You are operating a VIPs, one-eyed, you are doing a premium IOL where the patient already had a multifocal IOL and you are going to put on a multifocal IOL on this eye. Patient's eye is more important than your time. So anytime you feel that you need to slow down, please slow down. Do not try to speed up your surgery. Even many times I got to actually cool me down when I go to the theater. I know there is a list of 20 cases lying up. I got 3 or 4 hours to operate. And whenever I try to speed up, next day the patients have more corneal edema. Next day, 100%. I may save 20 minutes of the whole total time or 3 or 4 minutes per patient. But next day when I see my corneas are not clear. When I say, oh, I'm relaxed, I'm in no hurry, the list is small, even the hardest of the cataract will have no corneal edema. So slow down if need be. Patient's eye is much more important than your time. Thank you. See, because the nozzle probably moves sideways and may create a little bigger hole into the nuclear fragment and elliptical this thing. So you got to when to stop. If you deliver little too much of energy, the vacuum seal becomes loose. So just have to bury half a millimeter, 1 millimeter a tip. Particularly if the cataract is not very hard, you do not get a very good grip on this. So but if the cataract is soft, there is no problem. So if you give little extra energy, the grip is not very strong. Kumar, what is your session on? Is it related to the... So I think Kumar is very good surgeon. He will answer. He has got a... Yeah.
So, as you mentioned, nozzle, I don't use nozzle, I'm not using the Veritas. But what happens in nozzle is hard cataracts, the surgeon will be the most comfortable. So, on a centurion, you will not have a mislead, like how patients have mislead, surgeons also get misleads, because in nozzle you have phenomenal smoothness in cutting. But as you mentioned, occlusion is difficult because, as you said, it rotates and it creates a larger gap, so you're not able to bury and occlude. So, again, I don't know whether you use a straight tip or a bent tip. Sometimes in nozzle they use a bent Kelman tip. Now, the bent Kelman tip is very difficult to occlude. And I found it difficult to do very soft cataracts on nozzle because there is nothing to actually Phaco. It's soft, it has to be sucked out. So sometimes it might be easier to use a straight tip and not a bent tip on nozzle and might work. But then you won't get nozzle effect. That's the only problem.
The first cataract which you showed, the doing tension the hard cataract. If you do the tense stop and stop, and if you try to divide that hard cataract, very hard cataract, there is enough of capsular stretching. Does it affect the capsular
So you go on to my YouTube channel and you will see the hard cataract, how to operate. So you will see all, even the finer details. You will get 10, 20 points. Now I got to leave.
That capsular
I got to
stretching,
leave. I
is it,
think Dr. Kumar will answer.
is it elastic? The capsular stretching, is it elastic?
No, see the capillary stretching not take place when I told you that if you hold the nucleus at the periphery and split like this, like beam, split the Duryodhan into two, one leg over here, one leg over here. But if you put abdomen like Narasimha tried to bulge over here, put both the nails inside and split it, it will be difficult. So if you hold from one corner and split like this, like Bhima did, it will come out very easily. But as Narasimha did, that put hold the nail and try to split it, all the fibers is very difficult. You will need much more force.
Very good examples.
Sir, any experience with different choppers for the nucleus, hard nucleus?
Thank you. Yeah.
Okay. Take that.
Okay, thank you.